1 in our oxygen therapy and critical care case-based series. Today we will be talking about considerations for triage. We have our course director, Dr. Papytcho Ntambwe from Livingstone Central Hospital, Zambia, and our two co-panelists today, Dr. Ndaba from the University Teaching Hospital, Zambia, and Dr. Nyimbili, Maina Soko Military Hospital in Zambia. Before I pass it over, just some very few Project Echo etiquette and housekeeping. Our programming is based on a foundation of love and respect. Please respond kindly rather than react if you disagree with something. We will be using the chat function for questions and answers at the bottom of your screen. So please type and send all questions through the chat box, and please feel free to introduce yourself. If you can, turn on your video and position your webcam effectively to show your face if you're alone or to capture the whole group. As I mentioned, if you have any IT issues, send a message through the chat to Alana IT support, and we will be glad to help you out. So you know, this session is being recorded and your attendance is consent to be recorded. I just want to mention that we should all please be mindful of infection prevention and control. Try to limit numbers of people joining from one gathering place and practice physical distancing. With that, I'm going to pass it over to Dr. Papytcho to get us started.
Okay. Hello, are we there?
Yes, please go ahead. Thank you.
Thank you, Alana. Thank you for introduction. Though during that time, we're still setting up the audio for the room, but now everything is done. So we can really start up. Welcome everyone for this session on this Learning Resource Center. This is the first session for this type of learning. We encourage everyone who have registered to remain focused for the following session that will come. So today we are doing a triage case. This is a 57-odd man who presents with chills, weakness, and dry cough. So during session, we'll focus more on the practice change objectives rather than the learning objectives. So our first practice change objectives will be, as healthcare providers, we should follow recommended PP guidelines. As we know, guidelines in the PP are very important in terms of protection against the virus. And the healthcare providers should be trained in safe donning and doffing, as we're gonna go through it today and the next day. So patients with potentially contagious infections are isolated early so that we avoid dissemination of the infection to other non-infected patients and healthcare providers. The screening method for SARS-CoV-2 are in place. We're gonna see it as we go through the session. The healthcare providers should recognize and diagnose hypoxemia. As we were taught in the morning session, the use of oximeter can help you identify an hypoxic patient and take action. We also have to use a pulse oximetry to appropriately do the triage among the patients and prescribe an ideal oxygen therapy as the appropriate indication. As it was introduced earlier on, this patient who came to casualty, his main complaint was chills, weakness, and a dry cough. You as a healthcare provider who's on duty when the patient comes, you're in the emergency room, how will you evaluate whether this patient? We all know the different techniques on how to evaluate patients, but for this purpose, I will ask Dr. Op if she can train us through on how to evaluate a patient who come in the emergency room.
Dr. Hope, you are muted. Can you unmute?
Thank you. Good afternoon, everyone. This is Hope. To take you through the evaluation of the patient, I'll go through the standard practice that we use when evaluating patients in medicine. Typically, you want to take a thorough history when a patient presents to the hospital. When you are faced with a patient in this day and era who presents with chills, with fever, with weakness and dry cough, as our patient, like our patient above, you want to do a thorough history, but with specific emphasis on the symptoms of COVID, and also to help you determine the severity of the illness. So initially, when it comes to the history taking, you're going to ask specific questions about the onset of the symptoms. You're going to look for associated symptoms, such as fever in this case. You're going to ask about any difficulties in breathing, any shortness of breath. This will help you to determine the severity of the disease. When it comes to your past medical history, you also want to find out whether the patient has got any existing comorbidities, because we know that patients with underlying medical conditions such as hypertension, diabetes, obese patients, asthmatics, patients who are on immunosuppressive treatment, or patients who are immunosuppressed, we know that they're at risk of developing severe to critical illness. On our social history, our resource-limited countries, you really want to find out the type of housing your patient is coming from. Living conditions play a part on whether you're going to hospitalize a patient or whether you're going to ask them to self-isolate or to quarantine in their home facility. So just a little bit on the symptoms of COVID. We know that most of the patients who present to hospital with COVID-19 will come in with cough, they'll come in with shortness of breath, they'll have difficulties in breathing, they'll have fever, they'll have chills, they may have muscle or body aches, they may have associated diarrhea and vomiting, and classically, they may have a new onset in the loss of smell or the loss of taste. So as you carry out your history, you want to focus on these symptoms.
Thank you, Dr. O, for that clarification in terms of clinical examination. So it's very important that we get to follow the steps as described by Dr. O, so that we get to know exactly what the patient has come with. Remember, COVID is also a respiratory disease like any other. You can get more information when you follow better examination systematically. I would ask for the other participants who are following us through Zoom, if they have any question, they can go in the chat box and drop their question and we'll attend to it. So after getting this information, When you are interviewing your patient about his illness, you discover that he has 4 days history of chills, weakness, and dry cough. His wife is the nurse, and the hospital, the wife is a nurse at the hospital and tested positive for SARS-CoV-2 3 days ago. So his
Doctor,
wife has a pulse oximeter at home.
Hi,
And,
sorry to interrupt. I'm just wondering if you're in the room with other people, could everyone mute their device because there's a bit of an echo. People are having trouble hearing. Thank you.
Is it better now?
Yes.
As we were saying, the wife who's a nurse has used the pulse oximeter to check the saturation, and the reading shows that it's 89%. So his wife sent him to the emergency department where you are. What do you think is ideal? Will you examine this patient or you rush for a PP? Look, you can answer this question by dropping your answers in the chat box. So at this point, we'll ask Alana to click for us on the P box so that we can see the video, how it's moved on. There's a video on donning, which we're gonna play. It's a short video, but very interesting. We really have to watch it carefully so that we follow the steps, how it's done. And later on, after the video I've played, Dr. Ndaba will come through and talk more about the importance of putting a PPE and different type of PPE that are available.
How to safely put on personal protective equipment, or more commonly called PPE. We will demonstrate one way to appropriately put on or don PPE. More than one donning method may be acceptable to your facility. It's important that you receive training, demonstrate competency, and practice your healthcare facility's donning procedure. First, identify and gather the proper PPE to don, including an appropriately fitted isolation gown, a NIOSH-approved N95 filtering facepiece respirator or higher level respiratory protection, or if a respirator is not available, a face mask, a face shield or goggles, and a pair of disposable patient examination gloves. Perform hand hygiene by using alcohol-based hand sanitizer or washing your hands with soap and water for at least 20 seconds. Put on the isolation gown. Tie all ties or snap all snaps. You may need assistance from another healthcare provider. Put on the N95 respirator. When using a respirator with a nose piece, fit it to your nose using both hands. Do not bend or tent the respirator. Extend the respirator under your chin, protecting both your mouth and nose. Pull the top strap over your head, placing it on the crown. Then pull the bottom strap over your head, placing it at the base of your neck. Lastly, perform a user seal check. Do this by using your hands to cover the surface of the respirator and gently exhale, checking that the facepiece bulges slightly. Then, while keeping your hands over the respirator, take in a quick, deep breath, checking that the facepiece collapses slightly. If air escapes through the edges, readjust the fit of your respirator and perform another user seal check. Do this each time you put the respirator on. If a respirator is not available, put on a face mask. Extend the face mask under your chin, protecting both your mouth and nose. If the mask has loops, hook them around your ears. If it has ties, secure them at the base of your neck and crown of your head. Next, put on a face shield or goggles. Lastly, put on your gloves. Pull the gloves down so that they cover the wrist of the gown. You are now ready to enter the patient's room.
Okay. Thank you very much. Alana, can you go back to the main screen, please? Thank you. Whilst we are going back to that, I can see a number of participants accepting that there's need to put on a PPE. Now I'll ask Dr. Ndaba if he can make a comment on what type of PPE should we put and what time exactly the PPE should be put and the difference of PPE that can be used.
Okay, good afternoon, everyone. Thank you so much. I hope you can all hear me. Thank you so much for this opportunity and platform. Yes, so we are talking about an infectious, highly infectious disease. And as far as COVID-19 is concerned, the first thing you want to make sure is that you consider personal safety. So when you're working in triage, for instance, you're a healthcare provider, you need to consider personal safety first. And that's where the importance of wearing PPEs cannot be overemphasized. So this is the number one activity that a healthcare provider should consider before actually coming into contact with the patient. So from the video, we saw the different types of PPEs that were being demonstrated. And the level of PPE differs depending on what setting you are providing healthcare. In a triage environment, for instance, you are dealing with suspects, patients. There's a certain minimum PPE that can be worn. Talking about the availability of the different types of PPE, we saw that basically you have your face mask, you have your face shields, don't forget your gloves, you have your gown, you have your goggles. For instance, if you don't have a face shield, you can use your goggles. And then in places, for instance, in an isolation facility, you would also want to consider boots or shoe covers. So really the level of PPE that you put on will depend on the environment and what kind of activity in relation to COVID-19. So this is very, very important. And the way you put on the PPE and the way you put on, you remove or doffing is something that's critical, and all the steps should be followed, because infection, transmission of COVID-19 can occur during, for instance, during removal. So those steps are very critical and they should be followed. In resource limited places, things like in a triage setup, you will need to make sure that we always have the face masks. We need to have a face shield and a gown. Those should be your minimum, and gloves should be your minimum standard PPEs. And when we receive a suspected patient, we should make sure that we give that patient a mask as well in order to prevent transmission. So in an environment where you're caring for confirmed cases, it means you need to upgrade your level of PPEs, meaning that you would consider advanced types of masks, such as the N95. You need to make sure that you have your coverall as well. You have your boots on or your shoe covers, because you are in an environment where you're dealing with confirmed cases. So I think in a nutshell, the importance of PPEs cannot be emphasized. And before we attend to every patient, you need to make sure that you put on the PPEs and you are well protected. Thank you.
Dr. Ndaba have said it all, but we will not move without saying that in our change of practice, it's ideal that we create a place where, or a board, either in the patient room or where the patient are being isolated from. We print out the infographic papers on how to doff and to wear the different PPs. We stick them in there. And also, as we go back, we take time to teach our colleagues who have remained behind how to don and how to doff, because as you are teaching them, remember, it's a life that you are saving. Okay. So we're talking about how to isolate the patient. Basically, it's on how to triage this patient. So we would like to know if someone has done triaging before, and then when you're doing it, what was it all about? Yeah, thank you, Anna. And where do you isolate your patient when triaging them in your respective institution? So it's important to create enough space while you isolate your patient after doing triage. But on how to do the triaging, I would ask Anna if she could click on the box so that we see more about the information on triaging. I'm encouraging you all to get access to this website, because there's a lot of information in here. We might not be able to cover up everything as that we are doing this, but if we focus on learning, we can go on the website and get to find out more information that will be useful during our practice. As you can see, this SOP for triaging as described by CDC, it's well elaborated on this page. It goes down whereby you first have to know what is triaging, which simply means sorting out patients based on their presentation, from the most sick to the less sick, so that you focus most on those who are most sick, and then follow up in terms of the severity of illness. And then you also have to know what healthcare facilities can do to minimize the risk of infection among patients and healthcare providers, as it was emphasized earlier on by Dr. Ndaba. So separating patients who are sick and the protection using PPE is very important. Yeah. Dr. Op, do you have more information to add on triaging?
Okay, thank you very much, Papytcho, for that. First of all, I just want to mention that triage is a very important part of the management hospital response to COVID-19, because this is a highly infectious disease that we're dealing with. So as a hospital, if the triage is not done appropriately, there is a risk of amplifying the disease to the community by way of spread to people who are coming through the hospital. So the different triage systems which are out there, CDC has guidelines, which Dr. Anna kindly projected. WHO also has some guidelines. And locally in countries like Zambia, we do have some guidelines which have been promulgated by the ministry. I would just go through the key points. From the CDC guidelines, which will help us to triage patients effectively. First of all, during a pandemic like COVID-19, you want to ensure that patients who don't need to come to the hospital don't come at all. So through this triage, you'd want to employ communication methods such as telecommunication. Patients can be checked up on by phone. Those who just need a refill of medications, this can be refilled at home. Those patients who have mild disease or symptomatic can be followed up by this system. This way, you have less traffic of people coming through to the hospital. Secondly, what you want to do at a hospital setup is to make sure that if you are in a setup which has got multiple entry points, you may want to limit the number of entry points so that you concentrate your infection prevention procedures at that entry point. So you want to make sure that everyone who is visiting the hospital, the health workers, the patients, support staff, and visitors all wear a mask. You want to make sure that everyone who is entering the hospital sanitizes as well. You want to make sure that you set up a system which ensures a one-way flow of patients. So the entry point and the exit point into the hospital should be different. Upon arrival, you want to make sure that triage is done at the gate of the hospital or slightly inside. If possible, the triage point should be a separate building or an outbuilding which has got adequate ventilation. At the triage point, you want to make sure that you've got dedicated staff who are simply triaging patients. So dedicated nurses or dedicated healthcare workers who can triage patients according to the severity of diseases. It also becomes important that as you put up these mechanisms, you want to make sure that signage is adequate. You want to make sure that signage is adequate throughout the hospital. Patients and all the visitors who are coming into the hospital should know which direction to go, especially if you've created a one-way flow of traffic. As patients are waiting to be attended to, you want to make sure that they are adequately distant. So waiting benches should be put at appropriate distances to make sure that social distancing is being observed. On top of that, you want to make sure that patients are grouped or are triaged according to the severity of their illnesses. So patients with respiratory illnesses should be triaged to a separate area as opposed to patients who are coming in for routine visits. I must stress out that all the health workers who are involved in triage should be in full PPE to make sure that there is no cross-contamination and there is adequate protection of the health worker themselves. I think from the guidelines, these are some of the key points which we can implement in our health setups. Thank you. I don't know if there are any questions for clarifying.
If there's any question, you can just drop them in the chat box and then we'll attend to them as time moves. Thank you very much, Dr. O, for this wonderful clarification. There's a link that has been provided in the chat box where you can download more information about the CDC guidelines. But remember, these CDC, they're not a must. They should be implemented in accordance with your institution or made rather with your health guidelines. So On how will you screen this patient for SARS-CoV-2? What are other presenting symptoms that the patient can present? Can we write down some of the symptoms that the patient can come with so that we get into discussion as we are going through the more information that are found in this box that Alana will let us go through now. Alana, please let us go through to the pictures. So as we can see, this is a patient who can come with different signs and symptoms. Patient will come complaining of cough, shortness of breath, or difficulty in breathing. When checking the temperature, they can either be febrile or just have some chills. But we've seen also a number of patients coming without fever at all. You can also complain of muscle pain, vomiting or diarrhea, and loss of taste and smell. So these are the major things that we can find in a different type of patients. Not all of them will come with all this at once, but already you have some alarming sign and the complaint as the patient is coming to you. So you always have to be on the lookout of the COVID cases. Thank you, Alana. So the symptoms can range for a period of 2 to 14 days after you've been exposed. So even you, after a patient who was diagnosed COVID positive, you should also watch yourself between that period of time because you might later on start presenting some signs or symptoms of this disease, especially if there's a breakout in terms of protection. That's why Dr. Ndaba emphasized on how protection using correctly the PPE was very important for us, especially health professional providers. So what will be our practice change for this session? To make sure that we establish a screening station outside the facility, not when patient has already entered in and then we want to isolate them. We screen them before they enter, as it was illustrated by Dr. Opp. You identify the screening personnel and the questionnaire that you give them or a checklist. Screen everyone, even as we are reporting to work, we have to be screened, not knowing where we are coming from the community. Maybe we've managed now to get it from there. There are different apps that are there that you can use your phone, these Android phones, to make up appointments or set up an algorithm for triaging when it's possible. So we have to make rules whereby visiting to the patient who are hospitalized is very restricted. No one should enter, even for other patients who are non-COVID, because visitors when coming outside, they can bring the infection to patients who are hospitalized for other conditions. You triage high risk and symptomatic patients to area of isolation and provide hand washing supplies and ensure face covering. For hand washing, now many pharmacies or our own institution are able to provide hand washing. So it's just a matter of you having a small bottle that is refillable while you can be going to pharmacy and then they can give. I'm sure it's available. And mostly the easiest thing to do is frequently wash hands with water and soap. Thank you very much. And now we can go up. This is the patient that was in casualty. As an update, it denies not having fever, shortness of breath at rest, headaches, loss of taste, or loss of smell. He's talking in full sentences, but states he becomes short of breath with moving and eating. He has been less active and is mostly staying in bed or on the couch. A nurse obtained the first set of vitals and found that the heart rate is at 95 beats per minute. The blood pressure is 95/52 millimeter of mercury. Respiratory rate is 24 beats per minute, 24 rate per minute, and the saturation is 89%. His temperature is 35.5 degrees Celsius. So with use of pulse oximeter, you find that the patient is saturating at 89%. The question is to know, is this patient in hypoxia? Or rather, what is hypoxemia and what is hypoxia? How do you differentiate the two? We can drop our short answers in the chat box. And then we come later on for discussion. At the same time, you can also write down what are the common causes of hypoxemia that we know. And then we go into a further discussion with Dr. Ndaba. Alana, please could you click on the first box to see what are the differences? There's a short video that we're gonna watch, and this video will take us through the difference of hypoxia and hypoxemia. As we said, this material is available on the website. You can still come later on to watch it. For now, we just watch part of the video.
Diagnosing and treating hypoxemia requires providers understand its definition and how to detect hypoxemia using pulse oximetry or arterial blood gas analysis. When we breathe, we pull air into our lungs. Room air contains 21% oxygen. When oxygen enters our lungs, it travels to the alveoli, where it diffuses from the alveoli into the pulmonary capillaries. Oxygen then either binds to hemoglobin within the red blood cells or diffuses into the plasma. This is called oxygenation. Insufficient oxygenation is called hypoxemia. The rate at which oxygen is delivered to the cells and tissues of the body is known as oxygen delivery. Inadequate delivery of oxygen to the cells, tissues, and organs of the body is known as hypoxia. Every cell of the body requires oxygen for cellular metabolism. Lack of oxygen leads to cell death, tissue death, and organ dysfunction. The rate at which oxygen is removed from the blood and used by the cells and tissues is known as oxygen consumption. Oxygen in
Alana,
the
thank you
blood
very
can
much.
be detected in a number of ways.
At our own time, we can continue watching the video as access to the resource is free. Dr. Ndaba, could you make some comments on the difference between hypoxia and hypoxemia, please? Dr. Ndaba, are you still there?
Yeah.
Would
Can you hear me,
make some-
Papytcho?
Yes, I can hear you now. Thank you. I was asking if you could make some difference, emphasize more on
Okay.
the differences between hypoxemia and the hypoxia for our participant to understand better. Any comments on how to do it?
Yeah, so I think in simple understanding, without going into so much detail, hypoxemia would refer to a reduced concentration of oxygen in blood, whereas hypoxia, you are describing a reduction in the amount of oxygen available for cellular respiration. So hypoxia, you do not have enough oxygen available at tissue level. And so I think the most important thing for us is a clinical application of hypoxemia. As we are aware that hypoxia is one of the common presentation when we are talking about severe COVID infection, and measurement of hypoxia becomes key in patients that present with COVID. And so in low resource setup, in general, I would say you can measure the oxygen saturation using your pulse oximeter, which is a simple device that is non-invasive and currently available in most health facilities, including those facilities in low resource setup. An alternative and a slightly advanced way of measuring your oxygen tension in blood is by the use of arterial blood gas, where you need to draw a blood sample from an artery and then take it for analysis using what we call an arterial blood gas machine, or an ABG machine. So that will analyze the amount of oxygen that is present in blood. So pulse oximetry, which is just a measurement of oxygen saturation, the non-invasive method, has become very common because it is used to define the severity of COVID-19. And so the definition of hypoxia may vary depending on the kind of patient that you are talking about. But generally, you talk about an oxygen saturation or SpO2 of less than 94%. That should be a cause for worry or investigation. So measurement of oxygen saturation currently is key because of the fact that COVID will affect your lungs and will affect your ability to utilize oxygen.
Thank you very much. I guess now there's no more confusion between the two terminology. We get them clearly and we use them in correct timing. For now, I think we can just check the box to see what are the different causes of hypoxemia. And then we'll go to a table which is there, and then which can help us have an idea of the different causes of hypoxemia.
To diagnosing
Now, Alana, on the causes of hypoxemia.
in addition to
Yeah, as Alana is getting back to sharing the screen, we heard exactly how we can come up with a diagnosis of a patient who are hypoxic and how to confirm it. Can we go on the chest, on the picture, Alana?
in addition to diagnosing hypoxemia, it is also important for healthcare providers to recognize the common causes of hypoxemia in neonates, children, and adults. Hypoxemia is defined by low levels of oxygen in the blood and is detected using arterial blood gas analysis or pulse oximetry. Pulse oximetry is more widely available, but arterial blood gas analysis is more accurate when available. The exact level of oxygen saturation that defines hypoxemia is not clearly defined, as the level at which tissue hypoxia occurs is not known. However, most clinicians agree that an SpO2 less than 90% by pulse oximetry qualifies as hypoxemia. A hypoxemia diagnosis can be made using arterial blood gas analysis, but if ABGs are not available, a pulse oximetry unit can also be used. In the instance where neither tool is available,
Thank you, Alan. In the interest of time, we just
to
encourage
guide
our participants to go to the resource center for them to listen to the video on their own time. For now, if you can go back on the main screen, thank you. And then we go on the causes of hypoxemia by clicking on the picture, the lungs there, on the lungs picture. You can highlight the first one on top first, one by one. Thank you. We can see now what could be different cause hypoxemia due to low oxygen level, or could be diffusion causes, or poor binding of oxygen, or a difference or a mismatch ventilation perfusion ratio. When it comes to low oxygen level in alveolar, cause of that, is it because the patient is being hypoventilated, or because there is low FiO2? And when it's a hypoventilation, what could be the cause? So all these mechanisms, when you go through them, it will help you understand and guess what could be the actual cause of hypoxemia and give the ideal treatment. And it can be from different origins, either at the alveolar level, or of diffusion, or binding, or VQ mismatch. And when it comes to VQ mismatch, is it a shunt or is it a dead space? So all this could be different reasons why a patient can be hypoxic. Dr. Ndaba, could you please take us through the hypoxia cause algorithm?
Come again, Papytcho.
I was asking if you can take us through the hypoxia causes.
Oh, okay. I think Papytcho, you've explained. Actually, you've gone through some of them. As we can see, I will not go so much into detail because I think the algorithm clearly illustrates in detail how you classify hypoxia based on the causes, and some of the examples given under each classification. So hypoxia, generally, you have sort of a reduction in alveolar oxygen. So there's a reduction in the amount of oxygen available for ventilation or diffusion. And that can occur if there's low atmospheric oxygen or the patient is not breathing adequately. The patient is hypoventilating. Yeah, and then you have several other causes that may reduce the availability of oxygen in the lungs. Yeah, and so many causes of hypoventilation. It may be reduced level of consciousness. It may be muscle, neuromuscular disorders, etc., etc. I think the list is quite lengthy within the illustration. So you can also have diffusion problems, meaning that the oxygen is not able to diffuse effectively across the membranes, across the tissues, into the cells where they are supposed to be accessed. And then you have different conditions which can cause this, for instance, emphysema and several other pulmonary infections, your pneumonias, etc., etc. And then you can have a VQ mismatch, conditions that will affect your ventilation or perfusion, your blood flow through the alveoli. So any of those conditions would impair and oxygen diffusion and absorption from the lungs, and that may lead to hypoxia. So such conditions may include asthma, COPD, pulmonary embolism, and several other diseases that will affect your lung parenchyma. Yeah, and then you have a reduction in your oxygen binding capacity to hemoglobin. As we are aware, transport of oxygen in blood, a significant amount of oxygen is transported through binding to hemoglobin. And so if you have anything that interferes with effective transportation of oxygen, including, for instance, carbon monoxide poisoning, that will lead to tissue hypoxia as well. So I think in a nutshell, that would be the overall classification, but I would still encourage our listeners and participants to just look at the illustration or algorithm for further information. Thank you.
Thank you, Dr. Ndaba. I'm seeing participation of our listeners into the chat box. They've answered different causes of hypoxemia. They've mentioned anemia, ARDS, asthma, COPD, congenital heart disease. But I guess by following now the algorithm, you'll be able to know on what is really the cause of this hypoxemia, what should be the source of where the problem is coming from. Thank you, Alana, for that. So can we go back to the main screen, please? Thank you. We thought on what we can use for us to really diagnose patients with hypoxemia. And as we can see on this small picture, we are seeing 3 different vitals: the heart rates, the saturation, and the blood pressure. And these were the vitals of the patient. At the time of examination, his saturation was 89%. So we want to know what is the device that we use for us to make the diagnosis of hypoxia. And it was said there are different way of making this. It's either by doing the blood gas analysis or simply using a pulse oximeter. So now we'll go to Alana, please. Can you go into the box? We all know that to make a diagnosis of that hypoxia patient, it was due after using the pulse oximetry. And Lifebox was a big partner in this program, in many other programs that we've gone through. has put up a full road chart for you to go through on how to identify and choose different strategy for you to oxygenate your patient. So at this point, Dr. Op will take us through the oxygen road chart for us to see further what is in there.
Okay, thank you very much. I think before the COVID pandemic, very few of us paid attention or followed the oxygen escalation ladder as it is. But with this COVID crisis, I think it has really taught us to get back to the books and get back to the basics so that we're able to choose the right oxygen delivery devices according to the condition of the patient. This is important, especially in resource-limited setups, where you need to give optimum clinical care, but then at the same time, prevent wastage. So the oxygen escalation ladder starts with the simple nasal prongs. These are sometimes called nasal cannulae, or they're called nasal catheters. So the way these devices are chosen will depend, first of all, on the clinical condition of the patient. Once you check their pulse, once you determine the saturations via pulse oximetry. So the entry point is the nasal prongs. So whenever you're choosing a device, you have to look at the amount, how many liters per minute of oxygen you want to give. And then also you want to know what your effective FiO2 is. In the slide being shared by Alana, we're told, I think this will be shared. Alana, can you please share the slides? Okay, thank you. So the nasal prongs, these would deliver oxygen from 1 to 5 liters per minute. If your patient does not improve, you want to escalate your therapy by choosing a different device. So usually from your nasal prongs, in some facilities, you may have nasopharyngeal catheters. I think in our setting, these are not readily available. If you're not satisfied with the saturations after your nasopharyngeal catheters, you're going to escalate and choose a different oxygen delivery device. Your simple face mask is what you're going to use. Usually, this one will be a rebreather mask, an oxygen rebreather mask. This would deliver oxygen at a rate of 6 to 10 liters per minute. I want you to go through after this lecture to know what the fraction of inspired oxygen is with each device. So at your own time, just go through the training material. If the saturations do not improve after a few minutes on your simple face mask, you're going to escalate your therapy. You can use a face mask with a non-rebreather bag. This will increase the fraction of inspired oxygen which is being given. So with a non-rebreather mask, you're going to deliver oxygen at 10 to 15 liters per minute. However, you should remember that we also have a device called a Venturi face mask. A Venturi face mask will give a Venturi face mask will deliver oxygen at a flow rate of 4 to 15 liters per minute. There are various types of Venturi face mask. There are some which a single Venturi mask has a variable valve in which you can calculate the FiO2, the fraction of inspired oxygen being given via the same Venturi. So these ones are variable. We also have fixed Venturi valves. These are usually color-coded. Some are pink, some are green, some are white, and they will tell you the fraction of inspired oxygen that is being delivered. But typically, flow rates of 4 to 15 liters per minute. So the oxygen escalation ladder, that's with your nasal prongs, and it goes all the way up to your Venturi face mask. If you're in a setup where you've got high flow nasal catheters, these may also be employed. With high flow nasal catheters, oxygen will be delivered up to 60 liters per minute. So this is an increased oxygen demand patient with an increased oxygen demand. And these will also be able to deliver fractions of inspired oxygens of up to 100%. I must emphasize that as you are going through the escalation ladder, the patient's condition, the fraction of inspired oxygen, and the amount of oxygen that you're actually given is what will drive or determine the oxygen delivery device that you will use. Thank you.
Yeah, thank you.
Sorry, Dr. Papytcho, before you move on, I just want to talk about decontamination. Usually in resource limited setups, we do not have enough resources to dispose an oxygen delivery device after single use. So we have to make sure that we avoid cross-contamination between patients. So decontamination and disinfection becomes very important. So you want to make sure that these are physically cleaned after usage, and then they're soaked in a sodium hypochlorite solution for up to 30 minutes. Thank you so much.
Wow, thank you. If we don't do the contamination, we end up by taking patient from, the infection from the patient to the non-infected patient. And that will be a disaster in the hospital. Thank you, Dr. Opp, for that presentation. But on the same resource, there's also an algorithm for Livebox that we can go through at our own time when you access this information on the website. There's not much more to talk about diagnosis of hypoxia using pulse oximetry. But what we'd like to emphasize on is like we should go online, print the oxygen charts for use, not only for ourselves, so that everyone who has remained behind can follow this, and this will be very helpful. Yeah, we can also download and print the Livebox Triage tool, which is also online for use in our institution. All this information is for free. You can just access them on the webpage. Assign an equipment manager to process all information, all contaminated devices that has been used. Usually when it comes to the wards, it's the nurse who take care of this. And when it comes to theater, it's not the nurse, it's the helper, if we have one, who will do this. We all have to make sure that we give them clear instructions on how to do it. Otherwise, if it's not correctly done, you know what will happen. We'll be disseminating the infection even to non-infected patients. Thank you. So, you are dealing with this patient, you recognize right away that this patient is hypoxic. Its saturation is less than 90 on room air. While you continue your interview and physical exam, you decide to administer oxygen therapy. You are training and nursing students, which is most of the case for all of us in our institution where we work. We have these nursing schools for students who are in the ward. So it's asking you a question on to know how much oxygen is being delivered to the patient and why did you choose that oxygen delivery device? Partly of this answer was already tackled by Dr. Opp when she mentioned about the oxygen leather therapy. But as that for now, we'll go through again more detailed information that is in this box. If we ask you which oxygen delivery device will you use and at what flow, with the previous information that was given to you by Dr. Opp, are you able to write your answers in the box so that we see if you really understood as we are going through some further information?
Dr. Papytcho, there's also a question in the chat box from Stanley. He asked, when do you stop oxygen supplements once treatment has been initiated, or rather, what is the target?
Okay, that's a nice question. Sometimes we only know when to start, but we fail to stop it by fear of patient deteriorating. I think in this time, our target is not to have 100%. We're given already the target by Dr. Daba to say these patients, they will come hypoxic, but with the little oxygen therapy that we give, they can improve their saturation. If it can be slightly above 94, 95, I'll be happy, and then I'll disconnect this patient from oxygen. Rather, I will slow down from the eye device that I was giving to the lower until I wean him off oxygen. I might not stop it suddenly, but I will go rather down the ladder by dropping off from one eye device that was being used, the lowest, until I take him off oxygen. Dr. Hope, do you have some more comment to add on that one?
Oh, so Stanley, what I would say is that the escalation is also a de-escalation ladder. So what you're going to do is that, of course, these patients are usually hypoxic. They're usually hypoxic, the target of 100%, 94, 95, you would be happy to do that. And then you're going to decrease your flow rates or change the device if the patient is not desaturating. So you're going to titrate the flow rates and also titrate, I'll use that in inverted commas. You're also going to choose the delivery device depending on the patient's response. There is no hard and fast rule in terms of the timings because patient's response is very different. So you'll be guided by how the patient responds. So when you place the patient on the device, give them time, enough time, up to 30 minutes, to adapt to the device before choosing whether to escalate or de-escalating, but there is no specified time frame. Thank you.
Thank you, that was clear enough. Maybe to give him more information about this, we can go through this box, Alana, thank you, by clicking on the click so that we see what are different devices that can be used in terms of oxygenation. As it was elaborated earlier on by Dr. Ock, you can see the first stage, you go for nasal prong. You see the flow rate at which you give and the FiO2 that the device will deliver. So nasal prong, you go for 1 to 6, and then the FiO2 is 28 to 40. So if patient is not doing fine after giving this after some time, you can escalate to another level. You go to the Nasopharyngeal Catheter, whereby you check at the FiO2. The escalation is based on the FiO2. As you can see, the FiO2 here, it's higher than the previous, it's 45 to 60. Why are you moving for high FiO2? You want to make sure that patient is getting enough oxygen, not in terms of flow, but in terms of concentration. If still you are not satisfied after using the nasopharyngeal catheter, you move on to mask, to face mask. And on the face mask, we can use the plain face mask, the rebreather face mask, which has a slightly higher FiO2. And remember, when using the face mask, the flow rate should be higher than when you're using the nasal prong. If still not happy with this, you move to the non-rebreather face mask. When using the non-rebreather face mask, make sure that on the walls on the side of the mask, the valve is still in place. Remember, because we reuse these masks, sometimes the valves get misplaced, and then you just look at it being a non-rebreather face mask, whereby the valve has already blown off. Then it will not be a non-rebreather anymore. It will be a partial rebreather face mask. And look at the saturation that you get when using the FiO2 radar that you go for. It takes you up to from 60 to 95% when using the non-rebreather face mask. look at the flow. The flow is also gone high from between 10 to 15 liter per minute. And after that, you can go for Venturi mask. And Venturi masks, they're on different type. They've got different titration and they are color coded. So each color is attributed on how much saturation it can deliver. So oxygen escalation therapy, it's something that we really have to understand and when to use and when to escalate. After you reach your target and the patient is getting stable, don't leave the patient on the higher oxygen delivery device. You have to take him down until you wean him off oxygen. So all this information is available on the web page. You can go and download it for free and get used for it. Dr. Ndaba, Dr. Ob, do you have something to add up before we move to the next?
No, I've got nothing to add, Dr. Papytcho. Thank you.
Thank you. From the participants, is there any question? Yes, Dr. Ndaba?
Well, yeah, I was saying, I think we've actually spoken and mentioned the most important aspects of oxygen delivery system. And there are different limitations in terms of flow, as well as the percentage, the maximum percentage that can, FiO2 that can be delivered by that specific device. I think the most important thing also is I would encourage participants also just to physically appreciate these devices in terms of their differences, so that you can easily appreciate their function. Thank you.
Thank you very much. In terms of availability of equipment, we all know that our area of working environment, we are very limited with this. And Dr. Op emphasized earlier on about the guideline on how to reuse them. So for a quick reference, Alana, please, let's go through so that we see exactly how we can do it. So this is the decontamination and reprocessing of medical devices for healthcare facilities. Remember, when doing this, you have to encourage a person doing this to protect themselves. Remember, the viruses can stay on different environments for a different timing. So all this information can be downloaded on the WHO webpage, and then you go through them for further utilization in our institution and to make better guidelines to make sure that equipment is well sterilized and kept in safe place. Thank you. Thank you, Alana. So the patient we are dealing with, the current update. Yeah, thank you, Alana. The current update is that the student you are working with is very inquisitive. Next, she asks you, where does the oxygen come from? Do we have enough for all the patients? So those are the questions, because then they will just see oxygen being delivered, especially if you are using a hot type, yeah, which is very rare in our environment. Most of the institutions, we use either the cylinders or oxygen concentrators. And there will be another session further in some next coming weeks, whereby we'll talk more about the source of oxygen. But for now, we have to focus more on the practice change objectives for this oxygen delivery is to make sure that all healthcare providers follow the recommended use of PPE guidelines, and to make sure that we train our friend, our colleague behind to use correctly the PPE when donning and doffing. Don't forget to isolate your patients who are potentially contagious and develop a screening method for SARS-CoV-2. Recognize and diagnose hypoxemia. Remember, that could be the main complaint that the patient will come with. So if you miss it, you can put the patient in a wrong place. Use of oximetry to appropriately triage patients. We talked about triaging and the importance of triaging. Prescribe oxygen therapy using the most appropriate device available. We had a talk about escalation and escalation of oxygen therapy. I assume that information was given clearly. So remember, the key topics to review for this session: the infection prevention control, the PPE recommendation and safe donning and doffing, screening for COVID-19, triaging protocols, diagnosing hypoxemia, and use of oximetry as a triage tool. Starting oxygen therapy, when to start and when to stop. Non-invasive oxygen delivery devices, and disinfecting single-use equipment. Thank you, Alana. Yeah, so don't do the easy thing, do the right thing. As said, Marie Rose, a Nigerian anesthesiologist. Dr. Op or Dr. Ndaba, do you have something to top up?
Nothing really, Papytcho. I think the information was well presented and quite clear. The only thing is, I think we encourage participants to have a look at the website and appreciate the different material that we've covered. And so we look forward to the next sessions in future. Thank you.
Dr. Op?
No, I think you've said it all. Thank you, Dr. Papytcho.
Oh, mine is just to thank you two for accepting to be part of this panel and sharing your knowledge and your experience. Thank you also to participants from wherever you are following or listening us. Thank you for your time. We encourage you to visit the Learning Resource Center for you to access this presentation, and all the slides are available. The site also includes other additional information. As you could see, we're going deep to get some more information for us to share, but lack of time, we could not go through all of them. The link there, we share it in the WhatsApp group of this course so that everyone at any time you can get access to it. All you need is just internet and bundles. You can also join the big group, the WhatsApp group, where there's a monthly session, a different one in international. Remember now it's the global health. Information is coming from everywhere. People are sharing their knowledge, their experience. So we encourage all of you to come along so that we can share our experience. And thank you very much to our partners and support, Assist International, Project ECHO, and Stanford University for coming along for this session. Alana, you can wrap it up.
Yes, I think you've said it all, Dr. Papytcho. Thank you, everyone. And just to reinforce, all of the resources shared today and the actual module that our panelists went over is available for free on the Learning Resource Center. In our follow-up email, we will share the link to register for that so that you can access the full suite of quizzes and exercises and videos and links. So look out for that email. We've also recorded today's session, and so we will be circulating that as well in case you would like to rewatch or re-listen to the discussion. And then yes, please join our community WhatsApp group. It's a great place to share questions between sessions. And if you are having trouble scanning the QR code on the screen, you can also message us at the number indicated there. So I'll leave it up for just a couple minutes so that you can have a chance to do that. But otherwise, thank you so much for joining today, and we look forward to seeing you at session 2.
Thank you.
Thank you, everyone.
And thank you for waking up so early to be with us.